We're pleased to have Dr. Omar Mahroo join us today. Dr. Mahroo, you're an investigator on 3 papers presented at this year's ARVO meeting that involved the use of the RETeval device. Can you tell us a little bit about these studies?
Yeah, sure. These 3 studies, 2 are more scientific and one's got a more of a clinical focus. We've been using the RETeval in the Twins UK cohort, which is a big registry of largely healthy adult twins who've signed up for research studies at St. Thomas's Hospital in London. And we've recorded flicker ERGs using the RETeval on over 1,500, over 1,600 of the twins. And it's really, one of the aims was to get an idea of the distribution of flicker ERG peak times in a large healthy cohort, look at how it correlates with age. We found that it does increase with age, so it's important to have age-appropriate reference data. And it's also telling us something about maybe retinal processing slows a little bit with age as we get older, and we could investigate as to why that might be. And also, because these are twins, we can look at identical and non-identical twins and see how similar the recordings are between identical twins compared to non-identical twins. That gives us an idea of how much genetics contributes to the particular trait we're looking at. It's called the heritability. And we found that ERG peak times, as recorded with the RETeval, the standard ICEV ERG equivalent peak time, is about 75% heritable. So 75% of the variation in peak time seems to be attributable to genetic factors, which is interesting. And then further studies can look at what those genetic factors might be. The second study, also being presented on the same day, is we've been quite interested in myopia, the research group at King's College London. And you may know that the prevalence of myopia, short-sightedness, has been increasing dramatically over recent decades. So in some Far Eastern countries, it's like 80% of young adults are myopic, short-sighted, and the prevalence is increasing in the US and in Europe. And no one really knows exactly why. There are some theories and some risk factors have been identified, but there have been some big genetic association studies that have shown lots of loci in our genome, so lots of genetic regions that seem to be associated with myopia. So depending on what your genotype is at each of these hundreds of different loci, it can determine, it can give you a small risk of myopia, which is interesting and might give us an idea of what's driving the increase in myopia. So we know that the retina can somehow detect blur in images and direct the eye to grow appropriately. That's how we normally, in humans and in the animal kingdom, people end up having, people and animals end up with eyes that are the right size so that objects are in focus on the retina. It's the retina that's driving that. So we were interested to see if there are any associations between these genetic loci and ERGs. And so again, in our Twins UK cohort, it so happens that large numbers of them, we've already in previous studies established their genotype, their genetic identity at these areas in the genome that put you at risk of myopia. And we were interested to see if any of them associated with your ERG flicker peak time parameters. And it was an exploratory study. And interestingly, we found a signal in a gene called CNGB3 that encodes one of the proteins that builds the ion channel in our cone photoreceptors that give us our daylight vision and our color vision. It's the ion channel that closes in response to light. And if you have rare mutations, you get a disease called achromatopsia. So it was quite interesting that it seemed that common variation in this gene seemed to associate with the flicker ERGs as recorded with the RETeval. And then we looked at that same genetic association in another smaller cohort where we'd done conventional ERGs, and we found that same significant association. So this is really interesting because it suggests that it sort of supports this hypothesis that cone signaling, our cone signaling pathways, are important in driving myopia. And then the third study, which is being presented on Wednesday, it's more clinical. I see patients with inherited retinal disease, and ERGs are very important in characterizing many of these different inherited retinal diseases. There's over 200 genes that can be associated with monogenic retinal disease. And there's a particular interesting condition called enhanced S-cone syndrome related to mutations in a gene called NR2E3. And these patients seem to have many more S cones. So these are the cones in our retinas that respond to short wavelength light. It's only a few % of our cones normally, but these patients have loads more than normal, and they don't have functioning rods, it seems. If you deliver a specific ERG stimulus, you get a really big response in these patients, and it's pretty much diagnostic for the condition. And the RETeval has that as one of its protocols. So we were interested in a series of patients with enhanced S-cone syndrome to see if really the RETeval within minutes could pick up that this patient has this genetic cause. And we found it did in most of our patients. Some of these patients have an advanced retinal degeneration where they just don't really have a signal at all. But those with a detectable signal, you could really diagnose their condition just within minutes based on the RETeval recording. So we think that would be useful in future as these genetic diseases are more characterized and we do increase our genetic testing. It's going to be helpful to have such recordings to confirm that it is a mutation in this gene, for example. So those are the 3 studies we're presenting.
Thank you, Dr. Mahroo. I really appreciate that. The RETeval handheld ERG was used in all 3 studies. Can you tell me why the RETeval was chosen for these studies?
So I think it's a nifty portable device. You can get really quick recordings of cone system function using it. You don't need to take your patient or participant to some specialized room where there's conventional equipment. You can just do these recordings in clinic in a office clinic or research setting. So particularly, from the twins UK studies, these twins are having many tests. And if we want to do an ERG, yes, we've had some twins who could spare an hour where we did conventional ERGs with a conventional system, but sometimes you only have them for 5-10 minutes for your particular investigation. So it was really helpful, especially if you want large numbers, to use the RETeval, because we were able to train staff up pretty quickly and we were able to get such a large number of recordings. And similarly in clinic, often it's a kind of rate limiting factor. If a patient has to go for electrophysiology, sometimes they have to come on a different day to the electrophysiology department. They have to have their pupils dilated. Sometimes they have to go to a different hospital. At Moorfields, we've got a large electrophysiology department, but at other hospitals, that kind of department doesn't exist. So having a small device you can use in certain conditions, I think can really be helpful. You can get recordings of cone system function within a few minutes. And I found that helpful in a few different inherited retinal diseases.
Excellent. And how well did the RETeval perform in these studies?
I think it was performed well. We were able to get significant results both in the scientific research studies and in some of our clinical studies. The RETeval, as you know, comes with these sensor strips, these skin electrodes, and with skin electrodes, as always expected, is you get amplitudes that are very much reduced compared to conventional corneal electrodes. So I think in patients where the amplitude of the response is already low, sometimes the RETeval may fail to detect a recordable or detectable response. And so that needs to be borne in mind. And also position of the electrode has a big influence on amplitudes. But the peak time parameter we found in a previous study, even when the electrode was put in different positions, the peak time parameter was of the flicker ERG was remarkably stable. And so I think that is a particular advantage of the RETeval, a particular parameter that you can regard as reliable. And we found in a few different conditions that can be really helpful. So the amplitudes can be quite variable, but the peak time, certainly of the flicker, the 30 hertz flicker ERG, seems to be pretty reproducible.
And you kind of touched on this a little bit, but how easy was it to use the RETeval in the studies?
So it was really easy. We found that it was quite simple to train up staff, since they're applying skin electrodes and not electrodes that are going into the eye. Then maybe the training needed is less. People find it, our research staff and our clinic nurses find it a lot easier to apply the skin electrodes than to learn how to put in corneal electrodes. And then it's pretty, I think you can just, in medicine, we have this thing, see one, do one, teach one, which is probably a bit dangerous. Like you see an operation, then you do it once, and then you teach it. But that's how it was in the past. But the RETeval, it's almost like that. I wouldn't say you can see one and then start doing it and teaching it, but you can just see a few, and then you do a few, and then you're up and running. One thing interesting we found was when the research staff started off and they were unsupervised, they were putting the electrode in different positions, because the recommended position is fine, although sometimes it's sort of, you feel it a bit when you blink. So they were putting it lower down on the cheek, and we were getting some funny recordings, and that actually opened the door to another study. So why don't we just look at how it varies with position? And so a bit of supervision initially, I think, is important, and then after that, our staff have been able to run with it, really.
Excellent. Well, thank you very much, Dr. Mahroo. Really appreciate you joining us today. And once again, I hope that you have a good day there in the UK. Thank you.
Yeah, you're welcome.